Hello, 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 hello. Good evening, good evening, good evening, fellow friends and loved ones. Yes, thank you very much for your time. It's another Sunday evening, and it's our weekly discussion on various health topics, various health related conditions. And I'm sure that today, that is the 18th of October, we will learn a lot from today's discussion. Yes, kindly stay tuned, and you can share the page also so that we can be able to have a fair idea of today's condition. Okay, so today we are talking about a condition titled Golfer's elbow. Golfer's elbow. So when you hear golfer's elbow, I'm sure you will to understand or have a fair idea of what it's about. That it mainly affects golfers. We can have a fair idea of it, or we can also refer it as medial epicondylopathy. It's a big term. That's a science term, a scientific term. Medial epicondylopathy, or the previously referred to name as medial epicondylitis, but now by researchers and various assessments, we realize that there's no itis in the condition. Rather, it's a tendinopathy. So referred to as epicondylopathy or golf elbow. So these are outlined for the presentation. We have the definition of the condition. Secondly, the clinical relevant anatomy, and we have the osteology, that is how it's presented, the musculature, the etiology, that is the cause, the clinical presentation, that is how it's presented when you have the condition, what you're supposed to feel, how you're supposed to see the condition as, and then differential diagnosis, which is how you can differentiate it from other conditions that may look like the talked about condition, the diagnostic procedure, the outcome measures, the examination, that is how we're able to assess the severity of the condition, and medical management, the physical management, precautions, and some lifestyle modifications. Yes, so I'm sure today's topic will be a very interesting one, and I'm sure we will to get to understand the condition. Golfer's elbow. Golfer's elbow. Okay, so as we said initially, golfer's elbow is also referred to as medial epicondylopathy. That is, it affects this part, the inside part of the elbow. So we will see pictures to be able to appreciate this condition very, very much further. So it affects the side as the medial side. So in science term, this side is referred to as the one inside the elbow, the part inside the elbow is referred to as the medial side, and then the one outside the elbow is referred to as the lateral side. Yes, so medial epicondylopathy or golfer's elbow affects the inside part of the elbow, and so we'll be giving further explanations of the condition. And this condition is mainly due to tendinous overload or overuse injury. That is, when there is too much use of the inside part of the elbow. We have various activities that could imply that we use more or much of the inner part of the elbow, and this could result in golfer's elbow, that is medial epicondylopathy or golfer's elbow. Yes, okay, so some various structural processes or various structural presentation, that's anatomy of the condition, will be shown to you very, very soon, and then we can appreciate this condition. And so this condition also can be as a result of flexor tendon degeneration. That is, when the tendons in the inside part of the elbow begin to lose their effectiveness, their elasticity, that's the ability to hold the elbow in place. So you realize that when this part of the body, that is the elbow, begin to lose their strength, then we can see that there are structures there that are affected, and then they cause various functional deficit, that is not being able to use the hands, wave, even shaking the hands becomes very difficult, and then we need to see to it to be treated as early as possible. Okay, also this injury could go as far as beyond repair, so it's noted that the earlier we treat this condition, the better, so that we can be able to appreciate this condition the better. Okay, so just a statement by one of the researchers says that at times pain at the inside part of the arm becomes also severe. So most cases the pain is at the inside part of the elbow, that is called the medial epicondyle region. So an anatomy will be shown very soon so that we can see what it means to have medial epicondyle and then lateral epicondyle. I'm sure we can be able to appreciate it very soon. So this part of the elbow is called the medial epicondyle and lateral epicondyle. So this part of the elbow is affected, but when this condition happens, it could spread from the elbow right into the forearm. This is called the forearm, and then move right into the wrist, and then move also into the palm, then to the fingers. So the fingers, you can have the small finger affected, the ring finger affected. So these two parts of the fingers are mostly affected. So the ring finger, that's where the ring is placed, and then the small finger, so the small finger, and then the wrist, and then the ring finger. So the wrist is affected, so the whole part, this part of the body is affected. So from the medial epicondyle, the medial side of the elbow goes right into the wrist and then into the palm, and affecting the small finger and the ring finger. So people who have these conditions, when you ask them, they say I feel pain at these regions, and then we can be able to deduce that this condition is Golfer's elbow or medial epicondylopathy. Okay, thank you very much. So we are going to look at we are going to mention some anatomical names, and I'm sure we can appreciate it with the pictures very soon. So we have the bones around that region, as we have the forearm, we have the arm, this is the arm, your arm, this is your forearm, this is your elbow, this is your wrist, this is your palm, these are your fingers. Okay, you have in the forearm, you have the radius at this side. This side is called the radius, and we have this side called the ulna. We have the bone that we call there, and then we have a joint here we call the elbow joint, and this helps in the movement of the elbow. So activities that cause the elbow to move, when they have repeated functions, they could cause wear and tear of the structure there. Okay, so the main region where these structures cause the elbow to move is the medial epicondyle region. So we have medial and a lateral epicondyle region. But for the condition that we are talking about, that's a medial epicondyle region, we have turning the hand inside. So we have the hand turned inside, and then one that involves the hand turning outside. That is, this part of the joint has a structure we call tendon, and we have a tendon here that stretches right into the wrist, so it helps the hand to turn out. So just imagine I'm taking something, so my ability to do this involves a structure here, and my ability also to do this involves a structure here. So when this structure pulls in, I turn this way. When it pulls out, this structure here turns out. Okay, so that is the medial and epicondyle region. We have very strong tendons there that helps to turn the hand in and out. Okay, so the most site of occurrence of this condition, we have a structure we call the flexor carpal radialis, and then the pronator teres tendon. So this structure are mostly affected when we have a condition referred to as Golfer's elbow or medial epicondylopathy. Okay, so we are now talking about the etiology, and then it's referred to as less prevalent because these conditions don't really occur, but it doesn't mean that they are not likely to occur in various professions or occupations. So though the low incidence rate is being is likely to have been studied by researchers. We have about 9 to 20% of the prevalence of this condition in this population. Okay, unlike other or the broader condition that we might be talking about very soon in our later presentations, as tennis elbow, which is mostly affected by sportsmen, this condition we call golfer's elbow is less prevalent and involves a structural breakdown. That is where we have tears around the side, so the tendon here begin to tear, begin to have small tears, and then accumulation of these tears will cause major injury to the structure in the elbow, the medial side, the inside region of the elbow. And so we have irreparable fibrosis, that is hardening of the structure around the elbow joint, and then calcification. When we talk about calcification, means there are forms of crystals, there are forms of hardened objects in the inside of the elbow, and this limits movements in the elbow. So when we ask the person to stretch the elbow, there's difficulty in stretching because it has got to the very latter stage of the condition. Okay, so pain is experienced mainly at the inside part of the elbow. Let's keep it in mind. When someone has a golfer's elbow, person complains of pain here. When the person complains of pain here, it means that's the outside part of the elbow. It means it's unlikely, very unlikely to be golfer's elbow. Yes. Okay, so we mentioned that various occupational professions are likely to experience this condition. Athletes are also likely to experience this condition. They might present asymptomatically, that is, you might not see the symptoms at the early stage, but at the latter stage of the condition, where the condition is becoming very severe, the person experiences symptomatic pain. That is, we can observe, you can feel this condition or this presentation. Okay, so during the late stage, the person experiences severe pain. Sometimes the person cannot perform his or her activities very effectively. Okay, so one very important sport is baseball. So I don't know whether if you know about baseball, but yes, baseball is a very intensive game and needs you to be able to throw at a high pitch. So one other name for this condition is called pitcher's elbow. Yeah, so now we have three names that if you are asked about this condition, we can be able to tell us, yes, three names. So if you have an objective question that says what are the three names for this presentation topic, one, we have pitcher's elbow, we have golfer's elbow, or medial epicondylopathy. The last one is a very big name, but it's a scientific name. Okay, so it involves baseball players where they have to throw at a high pitch, at a high velocity to a longer distance, and sometimes it's very difficult, and then pain is experienced at a latter stage, very intense pain. Okay, so other sports include tennis, bowling. So bowling is, I'm sure if you don't know about bowling, it's a game where we have wood or some things placed, like stones placed at a far distance. So you have a big ball, so we throw the ball and then it hits either one or all of the objects at a far distance, and then when you're able to hit all of them, you be awarded a prize for it. This sport is actually not prevalent in Ghana. We can't see it, but when you go outside you can see it. It's called bowling. And then we have archery. Archery is where we have something like a spikes placed in a circular wood. So we have a pointed device, and the person throws it and then goes to hit the spot. So there's a small spot. If you're able to target and hit it, it means like archery. We have weightlifting, we have javelin throwing, we have racket football, we have American football. So these sports are all very involving, and then they could lead to golfer's elbow. But the main cause of the golfer's elbow are various professions. We are going to mention three very major professions that may have not likely to be mentioned, but they can cause golfer's elbow. A golf player is not included though in these three. But before we mention that, there's a scientific term that we call contractile loading, where we have excessive loading of the inside part of the elbow, and this involves two very, very important structures called the tendon. That's the wrist flexor group tendon and then the pronator tendon. And this, when they are affected, they cause, when they are affected, okay, so when they are affected, yes, when they are affected, they cause very, very bad limitations in terms of performing activities. Yes, so we have the wrist flexor tendon and then the pronator tendon affected. So these three various important professions are: one, carpentry. So the carpenter is likely to have, because he's hitting. As he's hitting, the inside part of the elbow is moving up and down. And then we realized that the first, one of the very important statements he made was that it's an overuse injury. So it means continuously using it for a longer period of time could cause the tendon to be affected, or the medial part of the elbow being affected. And then we can have golfer's elbow or pitcher's elbow or medial epicondylopathy. Okay, the second profession is plumbing. Yeah, I'm sure you've not seen like plumbers working well, but they are very much likely at a risk of having this condition. Also, meat cutting. So we have butchery. Those are the butchery where they cut meat. So the cutting of the meat involves them hitting. So this could result in golfer's elbow. So the three major professions are carpentry, plumbing, and then meat cutting. Okay, so one also likely cause is a single traumatic event. So just imagine you are boxing and then the boxer hits your elbow, or you are going somewhere and then you hit your elbow against the wood or a metal. So you're likely to injure the medial side of the elbow, and then this could result in an instant golfer's elbow or traumatic injury. Yes. Okay. So as we mentioned, the name medial epicondylopathy was just recently discovered, but initially it was referred to as medial epicondylitis, where they said there are inflammations around the side. But coming to notice this condition, there's very much less inflammation, that is swelling, that is reddening of the part. So they drifted it more to tendinopathy, where we have the tendons being affected. Okay, so another researcher also, or other researchers also state that the condition can also be called medial epicondylalgia, that is more of pain presenting. And to a particular school of thought, yes, it's true. Okay, so we have wears and tears around the elbow region, the medial part of the elbow region, and this could result in limitations. And then a very important point to note is that there's abnormal arrangement of the structures or the fibers around the medial part of the elbow. So when the person hits or injures the medial part of the elbow, the inside part of the elbow, the structures they become deformed, and then they're unable to arrange themselves in their normal structure. Just imagine you have an accident, or a car has an accident. When it's being repaired, it doesn't look like the same as before. Okay, so it affects the wrist flexor group, and then secondly, the pronator teres. Okay, so now we are going to talk about the clinical symptoms. When we talk about clinical symptoms, it means that it is how the person presents with this condition. First of all, the person has pain. So pain is a very, very important indicator of Golfer's elbow or medial epicondylopathy, or pitcher's elbow pain, and pain with radiculopathy, that is the pain radiating or moving from the elbow up to the forearm, sometimes the wrist, to the palm, and to the fingers, especially the ring finger, and then the small or the little finger. So this is one of the clinical presentation. Secondly, we have local tenderness over the medial epicondyle, and sometimes they move to the wrist, the forearm, and then the fingers. So we have local tenderness. Okay, so local tenderness, especially at the medial epicondyle, that is the medial part of the elbow. When we talk about local tenderness, it means the region around the elbow, that's the medial side, is mainly around the side. Okay, and then sometimes we could have stiffness of the elbow. That the stiffness mainly occurs at the latter stage, where we have fibrosis, calcification of which we talked about earlier in the presentation. Sometimes we have weaknesses in the hand and in the wrist. So sometimes the person complains of weakness in the hand, not being able to move the hands, even shaking the hand causes pain in the medial part of the elbow, the inside part of the elbow. And then sometimes pain or weakness in the wrist. The person complains of numbness. So when you move the hand around the forearm, this part of the forearm, or the elbow, the inside part of the elbow, the person says doesn't feel as compared to the other side of the elbow. The person also complains of tingling sensation, that is abnormal sensations in the fingers, sometimes the ring finger and then the little finger. There's pain also in a very important test, that is resisted wrist flexion or resisted pronation of the forearm. So when you talk about resisted flexion of the wrist, it means when you ask the person to bend the wrist forward, the person complains of pain at the inside part of the elbow, because there is a structure we call tendon that connects from the wrist to the inside part of the elbow. So when the person bends the palm forward, that is in scientific term wrist flexion, there's pain being elicited, that is pain produced. Or when they ask the person to turn the hand inside, so person's hand like this, and turn the hand and the palm facing downwards, the person complains of pain in the inside part of the elbow. These are one of the clinical symptoms of this condition. Also, the pain can be sudden, that is when you have a traumatic injury or traumatic incident, and the pain also can be progressive. So we have the pain increasing steadily. Okay, so now we're talking about differential diagnosis. Differential diagnosis is where we have other conditions that could mimic or that could look like this condition called pitcher's elbow, golfer's elbow, or medial epicondylopathy. Some conditions such as medial collateral ligament sprain. We have the adhesive capsulitis, that is frozen shoulder. They could also look like golfer's elbow, but it's not. But through various special tests or examinations, we can be able to deduce and then confirm this condition as such. We also have other conditions such as synovitis. We have lateral epicondylitis, that is the tennis elbow. We have osteoarthritis, that is degeneration in the joint. We have flexor pronator tendon strain. We have so many conditions, yes. And so one very important way of diagnosing this condition might not be through X-ray, might not be through MRI, might not be through CT scan, but especially by a physical therapist. So we have a special test that we call resisted wrist flexion. So when there is pain elicited there around the medial side or the inside part of the elbow, the person can be confirmed to have golfer's elbow. Okay, and then also we have pronation of the forearm. So these two movements together could confirm golfer's elbow. So the patient, you are patient to move the wrist, that is flex the wrist, so move the wrist forward and then try to turn the wrist inside, the arm inside, the forearm inside. The person complains of pain in the inside part of the elbow, so bending the wrist in like this and turning it out, so there's a stretch or there's sometimes pain elicited there, and then this could be confirmed to us having a golfer's elbow. Okay, so as we said, radiography or x-rays or MRIs might not be able to detect this condition, but they are very important, because if someone has an accident, there could be fracture, there could be tears around the structure that might not affect necessarily these two important muscles or tendons, that's the wrist flexor group or the pronator teres. And so if these structures are not affected, then we can rule out golfer's elbow or pitcher's elbow or medial epicondylopathy. And then now we can talk about or looking at other conditions. So now we're talking about outcome measures. So outcome measures are various clinical procedures that we can be able to use in our day-to-day activities as therapists, and then we can look on to seeing whether there is improvement or there is no improvement in the condition. So we have one outcome measure called the DASH outcome measure. That is, DASH means disability of the arm, shoulder, and then the hand. So this outcome measure helps us to be able to assess the movement of the arm. So if the person is able to hold, if they're able to bend the wrist to reach out. So daily processes or daily assessments, when the patient comes through and through, we can be able to see improvement and then restructure our therapy. Also, we have one outcome measure we call the use of the hand dynamometer, and this helps to be able to assess the grip strength. So in the case where the person has been affected by golfer's elbow, if you give the person the hand dynamometer, the person cannot really press on and the person complains of pain, and then this could be used the day goes by to strength, and then now we can be able to say yes, the person has been able to achieve strength and function. Also, we have the strain index, and this helps to evaluate the risk of developing a distal upper extremity disorder. So at an early stage, we can be able to use this outcome measure and then be able to see the effectiveness. Okay, and then also we have the upper extremity functional index, and this could be able to help us tell how functional the person is initially and throughout the therapy. So this could take a week, 3 weeks, 3 months to 6 months, yes, depending on the severity of the condition. So during the examination, we can check for tenderness by palpating. So we can have the elbow and then we can press on the inside part of the elbow. If the person complains of pain, we can go on further to do other assessments. The person also is likely to have local swelling or tenderness around the side. We could have warmth. The area feels warm, that is warm to touch. Person, when you put the back of your palm around the inside part of the elbow, the person, it feels warmth. It feels a bit warm. And also there is pain with turning of the hand out and then in, mostly in, and this could mean the person could have had golfer's elbow. Also, we have movements, that is bending of the wrist in and out. This could also cause pain. And then assessing other structures such as the shoulder and the scapula. The scapula is just here. This could also help us to conclude on this condition being golfer's elbow or pitcher's elbow. Okay, so now we talked about examination and then other topics, other subtopics. Now we are talking about the medical management. So how do you manage this condition medically? Yes, so we have facial elevation of the structure, that's the inside part of the elbow, and then tendon origin insertion. These are medical management. We have steroid injection, that's so we inject the place to relieve the pain, so that if there are any exercises the person can perform to strengthen the structures around the side, we can be able to do that. And also we have mini open resection procedure and a local anesthesia. These are all medical processes, yes, involving surgery, sometimes minor surgery. And then we have the autologous blood injection. These are all medical procedures. And now, as physical therapists, we are supposed to be able to relieve the pain at the medial part of the elbow, that's the inside part of the elbow, as best as possible. And so we have 3 phases in terms of recovery for a person with Golfer's elbow. The first is the relieving pain stage, where we go through a process acronymed PRICE, that is prevention or protection of the site. So we stop activities that involve raising or using the hand. So if the person is a carpenter, the person is supposed to stop carpentry for some time, and then he or she can employ others to go to take his or her place for that period of time, so that the person restores enough energy and function in the hand. Also, PRICE. So P means prevention or protection, R means rest, I means ice, C means compression, and E means elevation. So after protection or prevention, you're going to rest the place, minimal activity around the inside part of the elbow. You're going to ice, so using of ice block around the side. So these are the early stages of treatment for physical therapy management. So use ice around the side to relieve the pain. If there's any swelling or inflammation, it helps to allow it to resolve and the pain subsided. We have compression too, so you can use bandages to tighten the elbow in order to prevent swelling, or you can use any modified bandage to be able to compress that structure if there's swelling. And the elevation, so when you're going to sleep, you can put your hands on a pillow to prevent swelling, further swelling, and also to allow the blood to drain back in circulation. After going through the PRICE, that is prevention, protection, and then rest, icing, compression, elevation procedure, we can also use NSAIDs, that is non-steroidal anti-inflammation drugs, to be able to relieve the pain. So we taking them if the pain is so severe, they help to relieve the pain around the inside part of the elbow. Also, we have night splinting. So we have a device we call the splint. So we tie it around the elbow as you are going to sleep, so that in case you are turning up and down, we can have a better protection of the side to prevent further worsening of the condition. We have use of ultrasound therapy. So we have a device called ultrasound. So we connect it to electricity, or sometimes we have one that doesn't use electricity, and then we move it around the elbow, and this helps to relieve pain and then swelling. We also have high voltage galvanic stimulation. So these are stimulation. So you place it, there are parts that we place around the elbow to increase the strength of the muscles and then the tendons around the side, and this helps also to relieve pain. So this is the phase 1 stage. The second stage, that's the second phase, is where we have the swelling resolved, better function, and then being able to move the elbow at a very appreciable range. And then we moved on to the second phase, that is stretching. So we have minimal stretching of the elbow, and then we have progressive isometric exercises, that is being able to squeeze the palm and then move gradually the elbow. Yes, okay. So after the second phase, then move on to the third phase, that is involving return to function. So we have equipment techniques. So if you're a golfer, we teach you various techniques in terms of balance to be able to move and prevent the condition from recurring, because recurring of the condition could be disastrous. Yes, but that's why we need to teach you various techniques to prevent this condition from worsening. And then finally, we have post-operative management. So in case we have surgery, what are the various procedures that we can help as physical therapists to be able to return to function as best as possible? So after surgery, the first 7 to 10 days we rest, and then after we start activities. So we rest by splinting, that is using splints, and then skin sutures, that is when the place is sewed after the surgical procedures. The sutures are removed, that is the stitches are removed, and then after we start activities, after 10 days we can start moving the elbow. So the physical therapist pushes the elbow backwards and forward to release any likely stiffness or swelling in the elbow as a result of the splinting and the inactivity. So after 3 to 4 weeks we start gentle isometrics, and then after 6 weeks we start resistive exercises. Resistive exercises means when you ask the person to bend the elbow forward, you push the elbow backwards, so there's like a tug of war between both elbow. And then after 3 months we start strengthening exercises. So we have weight exercises, we get a heavy device, maybe a dumbbell, to move the hand up and down, sideways, like this. So these activities that as physical therapists we can teach patients to return to function and then have the maximal strength to be able to do his or her activities very effectively. Okay, so we've talked a lot about this condition. Now we look at some pictures, then we can be able to appreciate this condition as best as possible. Okay, so let's look at some pictures, and then we can have a very good understanding of this condition. Okay, so shall we go? So first of all, let's look at just a minute, sorry. So I think we'll look at, yes, okay, so this is the anatomy. So we can see the golfer's elbow very well. Yes, so this is the golfer's elbow. So these are the muscles we're talking about earlier on. So this is the pronator teres tendon, this is the flexor carpi radialis, this is the ulnar bone. You can see the ulnar bone. We can see the the ulnar bone. This is a radial bone, the radius bone. We can see the flexor carpi ulnaris is a tendon with muscle extensions, and then we can see the palmaris longus. Also, just a minute. So we can see also the medial epicondyle. This is the very structure you're talking about. So when this structure is injured, this is a medial epicondyle. I'm sure we can appreciate it more. Medial epicondyle. Okay. All right. Okay, so this is the stimulation I was talking about, the galvanic stimulation. So this helps to strengthen the hand. And then another presentation. This is the inside part of the elbow, the medial epicondyle. This is the lateral side. So you can see, look at the dot there. So the muscle stretch, this is the muscle bulk, the wrist flexor group. This is the wrist flexor group stretching from the wrist going up to the elbow. This is the inside part of the elbow. This is the outside part of the elbow. And this is the arm. Scientific name for the arm is called the humerus. Okay. And so this is the table tennis guy, but we're not talking about the table tennis elbow. We're talking about golfer's elbow. So we have icing. So you can see the icing here. Icing. So we ice the place. Okay. And then that picture of the medial epicondylitis. So these are the muscles. You can see the muscles here. The golfer's elbow. These are stimulation procedures. So we have galvanic stimulation. This here. These are points where we can stimulate to strengthen the inside part of the elbow. These are activities that physical therapists go through. So we have stretching here, so you can see here activities here. Okay, these are various activities as physical therapists we go through to teach patients. Okay, so these are activities. So going up and down, you can see activities bending up and down, range of motion exercises physical therapist goes through with patients. So this is a very good presentation. This is the inside part of the elbow. You can see the flexor group, and this is the medial epicondyle. This is the bone here, and this is the tendon, the wrist flexor tendon group. It stretches down into the wrist. Okay, so this is the golfer. Look at the way he's playing. So he's likely to injure this part of the elbow. Okay, so we also have, I forgot kinesotaping. This device is called a kinesotape. So we apply it here, from here directly to one of the muscles here, and then connect it here. So this is the radius and this is the ulna. So from the medial part of the elbow, that's the inside part of the elbow, goes directly to overlap onto the radius, and another one too from another one. This part overlaps onto the radius. So this helps to strengthen the wrist flexor group. So it's a tendon. A tendon strengthening takes a longer time as compared to the muscle injury. So there's more to do for that. So we can have a double overlay. So this is a black kinesotape also overlying into it. Okay, so we have also, this is a test I was talking about. So no, this is an exercise to strengthen the wrist flexor group. This is also the presentation of the pain the person is experiencing. This is a sketch. Okay, so this is the medial epicondyle. We can see the lateral epicondyle, we can see the humerus, we can see the radius. Okay, so this is also on a picture. So you can see the tear here, you can see the tear here of the medial epicondyle. Okay, so you can see the golfer. You can see, look at the medial epicondyle here. It's been zoomed in here. You can see, you can appreciate it the better. Okay, another anatomy, a very good presentation of the condition, the anatomy of the condition. Okay, and then you can see, so these are some of the pictures. We can see the pictures. These are some of the tests that we go through as physical therapists to diagnose the condition. Okay, all right. These are one of the, you can see Rafael Nadal. You can see the very famous man in the golfing arena. Yes, I'm sure we know his name. Yes, Tiger Woods. Yes, Tiger Woods. You can see him. Yes. So these are some of the pictures. Yes. I'm sure we can see. So these are some of the exercises that we go through. The squeezing exercises. We can see the movement exercises. We can see strengthening exercises. We can see the early stages. These are the exercises we do. The middle stages and the latter stages. Okay. So this is the anatomy. This is how the presentation of the condition is. Okay, so there are more to it. Okay, so yes, it's been exhaustive, it's been extensive, it's been so many things, yes, and I'm sure you've learned a lot. We could go on further, but our time has long overdue from 8:30 to 9, and so we thank you very much for your time, and then your being present with us. Yes, thank you very much for the presentation. And so a minute for any question, if you have any question for us to talk about. Any question. I can see so many viewers, I can see so many people around. Any question, just a minute for questions, please. Any question. Okay. So we'll be talking about our next condition. So in about a minute we'll be giving out the next condition to talk about. Yes. Any question, please? I can see Atabra on live. I can see Daniel, Dr. Daniel. I can see Daniel, another Daniel. Other people have passed by. Yes. Thank you very much. And then thank you much for the flyer. Yes. Genevieve. Yes. For the flyers and everything. And then thank you very much for Daniel, Mr. Pastor Ivanson Bra. Yes. He was passing through also. Thank you very much. Thank you very much, everyone. Thank you very much, everyone. And so our next topic is a very interesting topic. Very interesting topic. Yes, I'm sure we'll learn a lot in the next topic too. The condition is called coxygenia. It's even funny. Coxygenia. I'm sure we'll learn a lot in the next topic too. So let's please stay tuned, and I'm sure we'll have a very good time. Thank you very much. Have a blessed evening. Have a wonderful week, and may the Lord be with us all. Thank you very much. The next topic is coxygenia. Thank you very much. We love you. Stay tuned. Have a blessed evening. Take care. Bye bye.